Hello, my name is Edward Hirohara Noriega, and I would like to discuss seclusion and restraint within the psychiatric population. I took a personal interest into this topic because I have dealt with this particular patient group and would like to spread awareness to the physical and psychosocial effects that they can have. Here on the bottom, I incorporated my thesis. Physical restraints have a high risk of causing physical and psychosocial impairments, and hospital policies should reflect additional efforts to prevent these outcomes. I would also like to discuss the negative consequences of restraints, human factors that attribute to them, and changes and solutions that we can make to solve this problem. Amongst the negative consequences, restraints can cause physical harm. I've incorporated some pictures to help visualize some of these injuries. First is pneumonia can develop. Usually pneumonia develops because of aspiration as a result of chemically restraining someone with depressants. It can also occur as a result of prolonged immobility. Next, we have muscular dystrophy. It's also caused by prolonged immobility due to restraining someone. We have ulcers, also known as bed ulcers, which are painful and are a result of decreased circulation to bony prominences, also related to prolonged immobility, and deep vein thrombosis, which put patients at risks for developing strokes and heart attacks. Now, according to Moreland, back in 2009, physical restraints continue to predispose psychiatric patients to bodily harm, although acute care within these vulnerable patients has been recognized for a very long time. So, in other words, it's still an issue regardless of the amount of research we currently have. Now, in addition to physical effects of seclusion and restraint, psychiatric patients are affected psychosocially. My research has shown that patients have described the experience as aversive and parallel to rape or physical abuse. As a result of feeling this type of way, we predispose these patients to long-lasting emotional trauma. The next quote over, feelings of humiliation are prevalent. As a result of humiliation, we cause these patients to experience low self-esteem, which then puts them at risk of partaking in activities such as drug use, alcohol, or even suicide. Lastly, most former patients recall these experiences as negative. When a patient experiences a negative hospital experience, they refrain from going to the hospital when they need it in the future. This can cause them to injure themselves out in public or the environment, and can also cause them to get into trouble with law enforcement. Besides physical and psychosocial effects, one of the most influential factors to these patients' outcomes are the healthcare workers themselves. Oftentimes, the problem isn't the patient. This can include insufficient vigilance, which can lead to human errors. It can also include inadequate knowledge on restraint applications, and can also include inexperience that can result in inaccuracy in identifying a crisis situation. A Munich autopsy report reported a strangulation of a female patient who was restrained by abdominal binder. Keep in mind this abdominal binder was applied appropriately. Therefore, the problem was with supervision. Had this patient been supervised appropriately, she probably would not have succumbed to her demise. In the same report, 19 of 22 restraint-related deaths were due to restraints that were inappropriately applied. So it doesn't matter if restraints are correctly or incorrectly applied, they still pose a risk to this patient population. Now, although human errors are unpreventable, there are changes that can be made within current policies that can decrease the rate of restraint impairments. After all, if you reduce the rate of restraint, you automatically reduce the rate of impairment. Research conducted by Moreland and back in 2009 again stresses importance of nurses acquiring complex and comprehensive skills necessary to make accurate assessment of a patient's potential for immediate danger. The key word here is accurate assessment, because once again, if you can decrease the rate of utilizing restraints, then you decrease the rate of injury. So in order to summarize this, extensive education and reviewing qualifications is of importance here. Now, according to another one of my research articles, patients felt empowered after administration of what we call PCRRs, or post-seclusion restraint reviews. These are reflective questions that are in-depth and administered after a restraint event. The study concluded that this provided closure to these patients as well as promoted self-esteem and confidence. Now, another solution to decrease the rate of psychosocial and physical impairment is the presencing approach. And I included a quote here: an awareness of the shared humanity between the caregiver and the care receiver, in which the nurse is able to achieve a therapeutic use of self. This awareness of shared humanity is of utmost importance when it is necessary to use physical restraint as a last resort. In addition to this, nurses are self-aware and aware of their surroundings. The nurse is also expected to be present during a restraining, and while present, is expected to supervise the restraining team for excessive force and derogatory language. This helps the vulnerable patient to feel seen. This helps to develop trusting relationships between patients and the primary nurse as well. Now, in conclusion, adherence to alternatives like PCRRs, extensive education and qualification reviewing, and approaches such as presencing can reduce the rates of physical and psychological impairments and improve post-seclusion and restraint recovery. Thank you.